Uh, we will next hear from Charlotte Sabean, another Charlotte, and Rachel Skanes. Charlotte Sabean worked as a certified therapeutic recreation specialist at Digby General Hospital for 16 years. There, she works on the restorative care unit as well as the medical unit and has worked with dialysis, community, and pediatric populations. And Rachel became a certified therapeutic recreation specialist in 2018. Her passion for therapeutic recreation has taken her across the country, working in Ontario, Alberta, Newfoundland, and Nova Scotia. She now works with the Mobility Enhancement Program at the Digby General Hospital. And I'll invite them up now.
So Charlotte was 12 minutes, so I'm going to put that out there. Because no one thinks I can do this in 5 minutes, because Rachel's going to get 5 minutes of her 10 minutes. As well as we are both Charlottes, and we do actually work together on a lot of things. But I've been doing this longer, so I'm Charlotte number 1, and she's Charlotte number 2. So if you ever, need to get a hold of us. But she went first, so then it really doesn't even work for me today. So Rachel and I are going to talk about recreation therapy within dementia in acute care. And just some of the things that we've been doing. I'm pressing the beer one. Okay, so that's us, but you can see us here. And just want to highlight that we're going to talk about our medical ALC unit, which has about 20 beds, depending if we go over capacity, not because of COVID. And we can sit anywhere between 21 and 22. We do service a wide variety of population. We are a rural hospital as well. So we see kind of anybody and everybody. But a lot of our population is waiting for long-term care and is a long stay. So you're just being bombarded with rec therapists, whether you realize it or not. And I was so excited because I'm like, oh, there I am. Here's Rachel. Here's Charlotte. There's Corinne. Beth's even presenting. I'm like, oh, my dear. Like, I'm so excited. So what do? Just briefly, we're a systematic process that utilizes recreation and other activity-based interventions to address the assessed needs of individuals with illnesses and or disabling conditions as a means to the psychological and physical health, recovery, and well-being. As well, we're looking at the physical, cognitive, social, emotional, and spiritual functionings and how we can participate in a full functioning life. So we think we're pretty awesome, and basically everything that was said today, we're just like screaming like, we do that. So go back to whoever you work with and say, you need one of us. So when we look at our patients that come to the medical floor, this is our process that we go through. So we have a referral that comes in, then I'll complete the initial assessment, and we actually complete our own patient profile where we, because they're going to be with us for a long time, we want to get to know who they are, which we've discussed today even, and as well, then we can give that information to our counterparts when they go to long-term care, so say Charlotte. So we want to make that transition as easy as possible. And then we have, between myself and Rachel, who certainly can do my job, is in a recreation associate position right now. We're both, building rapports. We're looking at leisure sampling. We're looking at a behavioral care plan, so working with counterparts, but we also create one ourselves to help facilitate quality treatment. We're setting goals, and then we're implementing appropriate TR interventions, because what happens is we walk on the floor and we almost lose our mind because there's Minnie and Mickey Mouse coloring books on this patient's table, and so we steal them, we take them away, I give them to my kids, and then we put something appropriate there. So just because they're sitting there and they're bored doesn't mean that Mickey and Minnie are, the answer. So then we also look at the transition. So we're going to facilitate that transition to either long-term care, home, or potentially even end of life. And we hope that we can make that as easy as possible. We complete a rapid transfer form. So again, that is for continuity as well, especially going to long-term care or to another, maybe they're just transferred to a different hospital. So again, we're providing that information to our colleagues so that they know what we know, and again, to help that transition. We're going to communicate as well. We know each other. We're a small little group, so letting them know, giving them the heads up, and telling them what we've done, what works or doesn't. And then we're implementing routine as well. So we're trying to, simulate that to some degree, or going out in the community and showing them that, it's not the end of, the road if you go to long-term care. I've gone on with patients to even tour long-term care facilities just so that they, have an idea of what to expect, because sometimes there's just a fear of what that is, and when they see it, it's not, as fearful as they think. So some of the things, so I can do my own rambling, but not limited. Some of the things that we are doing is we do leisure sampling. So what are the resources, thank you, that we can have? So even just simple leisures like binders, dementia-friendly reading material, word searches, that sort of thing on hand. Woodworking, we have a guitar. Neither one of us know how to play it, but it's there. That's when we bring in physio, because Steve can tune it for us. Just flower arranging to sorting tasks. Another great thing, silver lining, I am a hairdresser now, so I cut every patient's hair, and I can go in there and just meet them once, and I'm like, I cut hair, by the way, and they're like, yes, please, right away. I'm like, okay, you trust me, that's great. So we do group programs, which are limited because of COVID, not my friend, but we have done exercise groups. Outings are huge, cooking and baking, gardening, shopping, holiday events, that sort of thing. We do a behavioral care plan if needed. We do the patient profiles, but also cheat sheets, which we put in the room so then other staff can know who that person is. Again, the rapid transfers, mobility enhancement program, which is Rachel. And then we're charting, and we're part of the team to advocate, who this patient is. So what does a care plan look like? So just really quickly, did it go? Yeah. We started this, I go by my baby, so my third baby when I came back and realizing that we're having a lot of people coming in with some behaviors. So we want to decrease those behaviors in a positive way. So we are all about not using pharmacological interventions or physical restraints. That is our mission in life. We want to increase engagement. We want to have a sense of purpose with these individuals, assist with the transition. Through this plan, we're decreasing the need for non-TR personnel being hired. That's one of our pet peeves. So a security guard sitting outside of a room, not interacting with the patient, is not our thoughts on how we can provide good quality care. Increasing socialization, decrease agitation and associated behaviors. And then the pro-attention, so actually trying to get there before the behaviors even happen, or we know maybe with sundowning or whatever, so getting there before that happens. And then, of course, the patient profile. So why should this be implemented by the wonderful recreation therapist? So again, we know boredom triggers agitation and behavior in those with dementia. We also know that simple leisures can help with dementia. We even heard that, right? It's not about, it's the quality over the quantity. The role of the meaningful conversation, engagement, and reminiscing. So again, that rapport building that we feel we do a good job at. Reduction in responsive behaviors attribute to experience in art, music, and activities of increasing stimulation. There's also relaxation-based therapies and skill training programs, and then reducing the boredom. We do one-on-one, individualized, person-centered interventions as well. We also want to look at different theories that can help with changing behaviors. Initiate the abilities of recreation therapy to build those rapports and decrease and de-escalate negative emotions and try to increase those positive ones. And then just other things that we've done is looking at like a token system. We incorporating the family as much as possible so we can have meaningful engagements with them. And then we can be that familiar face as well. And then, of course, all our approaches are non-pharmacological if you incorporate us. So with our behavioral care plan, we also look at the 7 A's. We also write down, which you'll see in just a second, Rachel will go over very quickly, why are the behaviors happening and what kind of dementia could possibly be associated with that. We also, of course, don't do this all by ourselves. We are smart, but we do focus on a multidisciplinary team. So Corinne, can be part of that, to nursing, to physio, whoever that may be along the continuum. And then, of course, patients and family. And then having the cheat sheets in the rooms, just so that they have a good idea or start conversations when they're going in there to do care or things like that. And then on pharmacological, again, strategies. And then we have a section on there for feedback from anybody. So they can be like, yeah, that sounds great, but in reality, it doesn't work so well. But we brought up this topic or whatever, and it went well, vice versa. And then also, we want to adapt to the cognitive domains that affect the behavior. So this is what it looks like, and I'm going to let Rachel talk.
Okay, so this is what the TR behavioral care plan looks like. So we try to incorporate the level of dementia. Oh, yeah, I'm taller than my counterparts. So we try to incorporate the level of dementia. So whether they're in an earlier stage of dementia to later stage affects how we try to engage the patient or what kind of group programmings that we're incorporating into their care. Types of confusion, so maybe some different diagnoses, or we've even incorporated this with people with mental health disorders at the same time, so we might include things like that on there. Any cognitive domains that are impacted and what that looks like, any behavior disturbances or barriers put forth by the 7 A's of dementia, and then any notes we have, so anything else that we've sort of figured out in our interactions with them. And so then we break down each behavior, so any behaviors that the patient is exhibiting that we want to kind of work on. So any responsive behaviors. Here we have wanders the halls. So then we've put our unmet need or trigger or why we're predicting these behaviors are happening. Next, we do our trial, so what has been trialed. So here, maybe they've come from the outpatient department and they've trialed an IM injection of Halidol, and maybe that didn't work so well. So instead, we're working on a recreation therapy consult. We're doing mobility teams, so maybe I'm taking them for walks or doing different things with them physically, small groups, simple leisure, things like that. So we have a case study for you. This is a patient who Charlotte worked on bringing his dog into the hospital so he could come see during COVID times. And then we'll talk about a patient called MR. So this patient was 77, had diagnoses of dementia, schizophrenia, had childhood traumas and abuse, lots and lots. Her reason for admission was they were hospitalized after a motor vehicle accident, and when they were transferred to us, they had broken a wrist after they came from a different hospital and they used a pelvic restraint on them and they fell out of the pelvic restraint. The patient had dementia and couldn't remember the accident or why they were in the hospital, and we would become incredibly angry with staff when they would try to explain why she was there. And so she had mistrust with staff. She had past sexual, emotional, and likely physical abuse, and at times could be sexually inappropriate because of that. She was exit seeking often and looking for family members, trying to go home, and looking for her car keys. She would raise her voice, become aggressive, which looked like screaming, raising fists. She would pull hair, swearing when staff wouldn't bring her keys or let her go home or try to tell her that she was confused. She did not like men and was triggered by hearing or seeing them, likely due to her past traumas. So some of our goals that we identified were identify and remove or even decrease the triggers wherever we could. So we advocated for no room changes. We kept her in a private room, kept men away from the room, and then I tried to get her off the unit as much as possible when she was becoming triggered for any reason. We offered consistency, routine, and different orientation strategies. We tried to make the hospital a safe place for the patient, something that she had never experienced in her life previous to her admission. We did de-escalation techniques such as validation therapy. We listened to her concerns. I did mobility enhancement program with her, which looked at doing a walking program. We did fine motor skills training with use of puzzles. We advocated for better pain management strategies after she had arthritis from her wrist fracture. And upon discharge, we had a really hard time getting her off the unit because she loved being there so much, and Charlotte actually had to get a dog to come to the unit to bring her to long-term care, but we didn't have to use any antipsychotic medications. So some of the outcomes we experienced were the patient no longer required physical or chemical restraints of any kind. They were very happy and well adjusted to the unit, which was the opposite of who we saw upon admission. She had a positive relationship with all staff who she was previously screaming at, kicking at, pulling their hair. Now she was saying, "God bless you, I love you, I'm happy to see you." The patient made friends with other patients on the unit and would actually advocate for them to have better care as well. She was very happy to see me, especially in the mornings, because I spent a lot of time with her. She called me Ethel every day, which was fine with me. And she would comment on whether or not I was on the unit at a specific time. So if I came 5 minutes late, she'd say, "Where were you, Ethel?" We provided pain management program and identified pain, which helped her behaviors a lot. And nursing was then asking why behaviors were happening instead of going to the medications right away, which we thought was a really good plus. So some of the other projects that we've been doing on our unit are distraction doors on the exit. So right now we have a bookcase, as you'll see in one of the pictures. We have a bookshelf now on our doors that's trying to make the unit a little more home-like and to prevent exit-seeking behaviors. We want all our doors to be fitted with true doors, which is like, if you've seen in long-term cares, some of the rooms look like a real front door. So we want our patients to be able to identify their rooms easily by having a real front door. Dignity frames in all rooms, which is the pictured there, the who am I. We want people to be able to go in right away and know who the patient is. Increase physical connection. We want to make sure staff is physically touching a patient. We know that hand holding is very important in dementia care and the use of touch. So we want to make sure that we're doing that, and other staff are as well. We want to create a sitting area. We don't have a space currently where patients can sit and socialize with one another, so we find that a real challenge in our care. Create more home-like patient room environments. Using a dementia garden. So we have a garden currently, but we want to make it more dementia-friendly. A Nordic chair, as you heard of from Charlotte, and a better daily calendar or orientation system for patients. Oh, and I skipped color contrasting items. So we want to have things like color contrasted toilet seats, dishware, soap dispensers, which would give patients with dementia easier use of some of our items that they have to use in the hospital setting. And that's it for us. I tried to blow through as fast as I could.